online session, and my co-chair will monitor the online session, and I will monitor the room, which is not very easy here due to this. So any questions from the audience, from the room? Yes, the microphone should come to you. And then try to speak close to the microphone, because otherwise it seems not to be very good transferred.
Sandro, the number of oocytes is not linear in the real physiology. When you predict a number of oocytes, in the real physiology, this number is not linear. You can have some oocytes haploid, for the other are not haploid.
Every predictive model, it's mathematical equation based on data set. So when you look at the study we did showing the probability of blastocyst euploidy, the curve, providing, let's say, the solid line showing the decrease. If you go to that particular point, they show absolute values, but remember that the 95% confidence intervals were there, representing the variability. But from the statistical point of view, if I have one embryo, this embryo has a probability of being euploid. According to our data set, this probability is primarily based on female age and type of sperm using for IVFX, in particular, decreasing when you use testicular sperm from men with non-obstructive azoospermia. This is for that data set that was then validated. And then it's an estimation. Obviously, we can have this variation. But if I have another embryo, if I say that the probability is 30%, the other embryo is, again, around 30%. So the embryos are individual units, although we can have some variability. So I think this is providing some guidance in terms of not to be absolute. We are not saying, and every single predictive model is the same. It's something to add, not to replace your clinical judgment, but help us to have an understanding what is, and also the patient have some understanding what the infertility journey could be.
Okay, first we shall have one question here from the online.
Yes,
do it alternatively.
the question is for Alessandro. Is the impact of high BMI on IVF results associated or not with PCOS syndrome similar?
I think that the answer is yes. There is a difference, because if we consider just a BMA is just one part of the story, because sometimes the high BMA is associated with PCOS, is associated with metabolic syndrome, is associated with many things. In my opinion, we should pay more attention to the insulin resistance rather than BMA. Because sometimes you can have women with elevated BMA but with good response in terms of X. But when we add the insulin resistance, then sometimes it's very difficult. It could be masked or could be not very evident. You could have more detrimental effects, not only in terms of the oocyte output, but even in terms of IVF success.
Okay, Raj, you're on.
Thank you. I have a question. I'm happy for either of you to answer it. These days, because of the pandemic, we reduced the number of visits that patients have to make to clinic. We simplified the monitoring protocols. And as a result, we often have patients who may not have had an ultrasound scan at the start of stimulation. Now, Alessandro, I think you referred to this a little bit. If they've had a baseline scan with good antral follicle count within, say, 3 months, is it reasonable to base the FOI or FORT on that scan?
Want to start?
Okay. I have discussed it with Professor Esteve just a few hours ago. I think that now we know that the past concept of follicle waves was superseded. We know that you have multiple follicular waves. And we know it from the fertility preservation experience. We know it from dual-stim experience. So to me, maybe it's more proper to assess it at the beginning of the stimulation in order to measure the FORT or the FOI index properly. But anyway, I agree with you that the difference in terms of antral follicle count between one method and another could be minimal. But anyway, if I would like to assess probably the FOI and FORT, I prefer to do it at the beginning of the stimulation.
I think it's a very good question, Raj. From the methodological point of view, if we are doing a study, a prospective study, we need to have the definitions very clear, how we do the AFC, how we set up the ultrasound, if we are using the 2D and setup, 3D, etc., and what are the follicles that we are measuring at the beginning and ideally at the start of the stimulation, and then calculate FOI. For me, FOI is like quality management system because obviously I cannot completely evaluate the hyperresponsiveness because I'm not looking to the follicles at the day of trigger. But when I get less oocytes, in my center, we do, it's a center fully operating in QMS 9001, ISO 9001, 2010. So we do cause-effect analysis. So I look into possible reasons why we had less oocytes than before. We check aspiration pump pressure. We check the trigger, many things. So I think it's KPI, as Alessandro suggested. So from the methodological point of view, my opinion, if any of you are interested to conduct prospective study, I think we need to set up, ideally, the way to measure FOI. Well, in the validation studies we did, because the database we created for the POSEIDON studies, validation studies with Hakan Yarali, Professor Yarali, and also Professor Len Vuong from Vietnam, we included over 13,000 patients. This is our database. So in that database, we included only patients who provided AFC or AMH within 3 months from starting the stimulation. So at least we have, it was inclusion criteria. So we can provide more information about FOI in near future. This is our ongoing study to see. Because when we discussed the publication proposing FOI, and we said 50%, below 50% is low FOI, it was completely arbitrary. It was not based on any scientific data. It was based on impression of the experts. It could be 60. But now we need to create, let's say, based on the database, first of all, what is the distribution of the FOI values in normal responders, POSEIDON groups 1, 2, 3, and 4, for us to really understand what is the profile of this population, including, for instance, if it's 50, the best value in a logistic regression analysis that could discriminate lower number of oocytes retrieved. So that could be a thing that help us clinicians, and also to set up the future trials on how we approach FOI, and if we need to combine with FORT for the evaluation. I think we need to simplify, as you said. I mean, I don't want to do so many scans. FORT has a problem because we need to look into the beginning, look into the end, but eggs are already there because everyone will count eggs, and we can do FOI using total number of eggs or FOI M2 using metaphase 2 oocytes. So this is something also that we can explore, but obviously in the study standpoint, design and conducting a scientific study, we will need to monitor from the beginning. This is my opinion.
Okay. Yes, Ariel. And after that, Carlo.
I have a question to Sandro. I believe that for simplification, you made a distinction between ejaculated and testicular sperm, non-obstructive azoospermia. But some cases with ejaculated sperm, sperm quality is very, very poor in terms of morphology or very high DFI. So in your experience, how does that affect the blastulation, and should be any correction done for that? Should you take it into consideration?
I think it's an important question. If I look into the data set that we had, our center deals with a significant number of patients with severe male factor. This is why we had the power to analyze testicular sperm from men with non-obstructive azoospermia. So this is something that we do almost every day. We couldn't find actually a detrimental effect of DFI. It was included as a variable, and also ejaculated sperm as a whole. So based on the data, the only significant factor was really, as Filippo showed also in his presentation, the study that they published in Human Reproduction, the same trend. But if you ask me personally, I think that patients, for instance, with cryptozoospermia, I mean patients with, you know, the few sperm that we find many times only after centrifugation, we don't have the same results in terms of blastulation compared with testicular sperm. In many cases, we go back to the testicle to take sperm from these patients. One example is high DFI. We are now exploring more and more taking sperm from the testicle. So I believe that if we expand the data set and having more higher proportion of patients with crypto or severe abnormalities, as you pointed out, I feel we might get some adjustments. So, and your point is well taken, because I think for every single predictive model, and if we could also add artificial intelligence, I mean, let's say that everyone start to use, some good proportion of you start to using the ART calculator, and we had the opportunity to start to input data that could refine the model, and eventually other variables could be included. But to answer directly your point, my perception is it affects, and for the data set, we couldn't find the difference. The last point I want to comment is that what we found, and also it was also in the paper by Filippo, is that it's not the issue when we have testicular sperm from patients with non-obstructive azoospermia. It's not that it's having a directly effect on euploidy because the sperm is defective. Well, we know that this is the most severe scenario, but the problem was the cascade, because you start with injecting sperm from the testicle, the fertilization rates for most of us will be lower than the ejaculated sperm, blastulation will be lower, then you end up with lower number of embryos. And then we go for the proportion of euploidy in that cohort is quite similar, but actually the cascade was making the situation more complicated for these patients.
Okay. Carlo?
So,
Carlo?
congratulations for both talks. And Sandro, for the first time I realized that we have to add the taxi driver in the in Poseidon panel or papers. So, just one comment on the question of the matter of FOI and a question for Sandro. Yes, you're right. I totally agree. We need to have an ideal situation, meaning antral follicle count at the beginning of the cycle. This is the cleanest and the most reliable way. But when we met in the Italian Society for Fertility and Sterility to try to use FOI as a KPI, a lot of doctors said yes, but it's difficult to measure any time on day 2, on day 3. But let me tell you something. This is something that we're trying to validate, but it's just an idea. The vast majority of centers make the first check on day 5. So day 5 is just 2 days after the timing for standard anti-follicular count, because it is within day 6. So you have only 2-3 days stimulation. So the smaller follicle are still there. The larger follicle usually do not overcome 9-10 millimeters. So you have a good representation of the baseline, and probably this is just in a hypothetical future way, and we are trying to call it something like late FOI because it's made in the second in the middle of stimulation, sufficiently close to the beginning of stimulation, with no significant alteration yet of the initial anti-follicle count picture. This is an hypothesis we can work about in the future. And I would like to know your opinion on this, and Alessandro's opinion. The question is, we were talking about it in the past, but we didn't mention any more. Do you think it makes sense to correct the ART calculator also for oncologic patients? Meaning that when you freeze eggs, you have to consider survival rate, you have to consider restoration rate of toad oocytes, because sometimes we have time in this patient for second stimulation. So in terms of counseling, do you think that some additional, some adjustment can make sense in the RT calculating for frozen, for when you have to freeze eggs, not for procedure, but freezing eggs for, I mean, oncology or not oncologic, or patient that want to preserve fertility, to calculate the ideal number?
You start with.
I thank you for the question. I believe that yes, the late FOI could be a good compromise in order to, to reach the clinical routine activity in order to get more information about FOI. Because if we do not explore it, maybe we do not explore the pathogenesis of hyperresponse. So we still, we can still have some difficulty to treat properly this patient. Regarding the use of the POSEIDON calculator, I think that it could be even more useful for women who underwent fertility preservation, because in this case, the patients need at the moment an answer. Would like to know, but if I retreat 10 eggs, what is the chance in the future? Because we are talking about patients that will perform the IVF procedure 5 years later. If we think about the most common cancer, it is the breast cancer. So I think that if we, in the future, will develop better this calculator for the woman who underwent fertility preservation, could be a very, a very good tool. That's my opinion.
So, Carlo, thank you very much for the questions. First of all, the first one, I love pragmatic trials. So I think if you are very strict, I mean, in the randomized control trials, we learn that it's very hard to realize and make it happen. So a pragmatic trial like that could be interesting to explore, for sure. So I think it will be very informative. Concerning adding variables in the ART calculator, in that regard, my answer is no. I think that if you have in your center the, survival rate of your program, cryopreservation program, and you know that it's 90% or not, just apply that reduction factor in the estimation. That will make the life much easier, and I think we'll get the results. I mean, when we discuss with the statistician, they say, well, the larger the database, better, because obviously we can identify certain characteristics, but up to a certain point, because more noise you include, it will be more difficult for the clinicians to use. For instance, when we decide to use this lasso model, I learned that we can simplify our thinking using statistical knowledge. So I think that any, suggestion concern, okay, I'd like to use in that application or that application, we need to validate. But from a pragmatic point of view, I think we just apply some reductions based on the program you have, like for freezing and thawing embryos or oocytes, and I think we can have an estimate corrected using own data, which is also valid.
Okay, I think we shall conclude now this session, which was very interesting and informative. We thank the two presenters and panelists. I also thank my co-chair. And you have now 20 minutes for a coffee break to keep yourself alive for the next session that will start 20 minutes from now.